Yeah. She'll be at the podium, na?
क्या करना है आपको?
Good morning. Yeah, I'm Dr. Ashwini Vivek. I am from Pune. I come from Pune, basically Mumbai, married in Pune, practicing in Pune and practicing in sexology for the last almost 15-20 years. We have been trained extensively under the guidance of Dr. Mahendra Vatsa and Dr. Ananta Sakhe in Pune. So, and we have been guided all throughout our journey by the greatest stalwarts in our industry. As a female sexologist, in the beginning, there were a lot of challenges to practice sexology as a male doctor, because India is not a country, not just India but anywhere in the world. It's not a country who will take to these subjects very kindly. There are still full of lot of myths and taboos and misunderstandings and attitudes in India especially. So it is that reason actually I decided to practice sexology. I am a pass out from Vedas Medical College and I had done multiple courses in sexology, as well as I just acquired, I have been granted the fellowship from CSEPI and I done some marriage counseling, psychotherapy courses, and I exclusively practice sexology as a patient. So that's
now we are facing a difficulty at this one particular laptop. Not able to open it. Unable to load the slides.
Is it downloaded?
Yes, yes. अरे भाई ये पहले सब टेस्ट करने का रहता है. ये क्या कर रहे हो तुम? No. हाँ?
Even if the next one starts the project, it's not connecting, so those slides won't be project.
It has to be the 9 o'clock or it's they can
load it. Not going from our side, but from the technical side.
It was not.
हेलो विवेक, नीचे नहीं देख देखा पीपीटी चालू हो गई, प्रोजेक्टर में दिख नहीं रहा, विंडोज पे दबा रहे तो भी नहीं दिख रहा, सही दिख रहा है, जल्दी आ नीचे।
बेटा पहले टेस्ट, अरे कुछ भी हो ना भाई, it is your responsibility to arrange all this. You cannot get away by saying that this is not my laptop.
I'm not telling my laptop.
अरे भाई अभी start somehow यार.
Sanjay.
F1, F7.
विंडोज पीसी होता है।
F7 so
Technically
depends on which version of laptop it is. Which laptop?
You want my laptop?
You have
Yes, my laptop
did
is
you
there.
check it before?
Yeah.
हो रहा था.
हाँ। अभी तो मुझे
Another laptop.
इस लैपटॉप में आया अभी पीपीटी को बोला।
So do you have? Can we try?
ऊपर जा.
Okay, so let's just interacting somehow before the technology gets into this thing. You know, the good old days when we used to maximum load the presentations on a floppy disk and used to carry our own laptops. And before that, we used to write everything on the blackboard or whiteboard, and we used to do the lectures and presentations. So we didn't have to get crippled by so-called crutches of technology, right? Because at the end of the day, finally what matters is what we are here for a conference, for an academic conference. So we are here to learn. Okay. So before we begin, okay, you have a child in the audience?
Yeah.
Okay, it's not coming from outside, right? Okay, fine. Very good. So I first of all thank the CSEPI for giving me this opportunity to present a small topic in the beginning and the first lecture of this session. It's a huge journey for us when we started from scratch in 1995, and now we have come to this stage where we are on the stage of CSEPI, and I really thank the organizers for giving me this opportunity. The topic today given to me is sexual desire disorders in women, and I think it's a very apt topic because it is the first and foremostly important thing when it comes to one's sexual functionality or sexual physiology. To be able to be functional in sexual way, one has to have the desire first, right? So that would be the topic today. For all those senior as well as junior people, this is mainly a scientific based content. Now, as we are aware that the sexuality as such is developed because of is based upon the reproductive organs, genital organs. Genital organs are not just vagina and uterus in women, and not just penis and testes in men, but the genital organs of the reproductive organs, they begin from the anterior pituitary, okay, from the pituitary to the hypothalamus to the gonads, what we call as testes and ovaries in females and males. Now, the whole function of the reproductive tract is not just the structure, but it is the functionality of it, because it works on different hormones and different neurotransmitters. As we are aware, the whole physiology of the body is based upon this. When it comes to sexology, actually, what we are not looking at not just the cellular or the local physiology, but we are also looking at its connection from the brain to the mind, to the emotions, and to the actual function of the reproductive organs. Unlike in animals, the reproductive organs in human beings do not just do the act of procreation. They do not just do the act of procreation. So even though one sample of semen might contain millions and crores of sperms, yet every intercourse or every semen sample is not going to give rise to a baby. It's not what we aimed at. Human beings are evolved in a way that human beings basically use sexuality as an expression of love and bonding. So we are highly evolved, and when the intellectual things come into the play, yes, things get more complicated. And we are still, over so many years, we are still trying to understand how things work for us and how we can get past any difficulties that all of us have. Because we are not just sexual, but we are psychosexual beings, the connections between the psyche, the brain, and the reproductive organs, and the physiology, and the connection between two people who are involved in sexual relationships become important.
Next slide.
Try now.
Try now.
The laptop.
Can be done. She will ask next, then you change the slide from there. You change it from here.
The laptop is getting stuck. I am resolving it. Just give me a moment.
I request the next speaker to submit his PowerPoint so that we don't. Dr. S. Murugan is the next speaker.
No, third. I am third.
I am second.
Mine is third.
Sati sir. No, sorry.
Ma'am, you can say next. You can say next.
Are you working the slides now?
You have to say next.
Next. So let's begin the formal thing now. Desire is the main basis on which the whole of the sexual function depends. Right? The whole sexual response cycle of excitement, plateau, orgasm, resolution basically begins from the desire. So unless there is desire, none of the next events are going to happen. Next. Next. So the female's hyperactive sexual desire will be either normal desire when there is not a disorder, or it will be hyper desire, more desire, or it will be less than normal desire. So first we are going to talk about, the most talked about subject is hyperactive sexual desire disorder. And in women it is supposed to be very, very common, because women are basically less pro as far as when it comes to initiating sex as such. It is defined as the deficiency or absence of sexual fantasies and desire for sexual activity that causes marked distress in interpersonal difficulty. Like I said, we're talking about desire, which is an innate thing. I'll say next.
That's not working.
I'll just say next. Is that okay?
Yeah.
This is coordinate. Right. So, basic the absence of fantasies and desire for sexual activity is called as sexual desire deficiency disorder. Now, the desire is different in men and desire is different in women. In the sense that both are innate things, but there is more expression from the men's point. But women are not so expressive of their desire. Because of this cultural or genetic or hormonal differences that men and women have, there are factors that we need to consider when we need to compare and classify the female sexual desire disorder. The responsive versus untriggered desire. Not many women will initiate the sex. Men always initiate or are expected to initiate sex. So women's desire is said to be more of a responsive thing than the untriggered desire. There is relative infrequency of unprovoked sexual fantasies in women. Are you able to hear me? I think it's a small one. Now, because of this, considering the gender differences, the general definition from DSM-4 has been now evolved to DSM-5 definition, where there is also elimination of the distress as a diagnostic category. Because women do not initiate, though they don't get bothered much about it. And that is the hypothesis. Okay. The significant overlap between desire and arousal. When there is desire, there will be arousal. If there is no desire, there will not be arousal. In fact, both the things go so much in together. Because women not always will watch porn or keep on thinking about sex. Right? They are usually get excited by the touch and by the proximity of the partner. So because of that, in women, the desire and arousal, they become very, very close together. So, because of that, next, the DSM-5 definition of desire has included both arousal and desire together. So the DSM-5 says the female sexual dysfunctions are classified into sexual interest, arousal disorder, or orgasmic or genitopelvic pain or penetration disorder. Next. As we have said earlier, the complex interaction of multiple neurotransmitters and hormones acting both centrally and peripherally causes the sexual functionality to be possible. The sexual desire is the result of a complex balance between inhibitory and excitatory pathways in the brain. Next. Next. Same is the condition with arousal. Even arousal will be affected, rather will be a result of multiple neurotransmitters, which will be estrogen, testosterone, progestin, and they will create the nitric oxide into the genitals, which will then cause the vasodilatation changes into the genital area and the lubrication and the arousal response. Next. When it comes to women, in men you will say there are about 4 hormones per se, which we have the interplay, which will cause the reproductive life. In women, there are about almost 8 hormones, which will cause this thing. And plus, we have the basic neurotransmitters like dopamine and nitric acid. Now, the female sexual reproductive life experiences may be uniquely affect several changes in the female reproductive life will cause different changes in the sexual desire. For example, menarche, menstrual cycles, pregnancy, postpartum state, and lactation. When the woman is taking hormonal contraceptives, or when she undergoes oophorectomy plus hysterectomy, or she is in a perimenopausal or menopausal state, surgical or natural. Next. Per se, amongst the FSDs, the incidence of desire disorders in females is up to 56%, arousal up to 37%, and orgasmic disorders are 63%. Dyspareunia being 31% again, and vaginismus. As we are well aware, all these conditions at one point in time they will have a total overlap or a conflict with each other. It will be difficult to find out which one is which. Next. As we said earlier, all the hormones starting with the GnRH, which is affecting the pituitary, starting with the pituitary, and we come down to the gonads and to the local end organs of the reproductive life. Next. Per se, the key hormones though are the estradiol, estrogen in women, and testosterone in men. They are supposed to be the key hormones when we are talking about just the desire part of sexuality. And this is how they vary throughout the lifetime. Like in a woman, the estrogen is shown in red. In men, the testosterone is shown in blue. Next. Similarly, women will also have testosterone throughout their lifetime period, as shown in the years of age. And in men, will also have the testosterone graphs like that. Also, per every menstrual cycle, also the woman will have not only estrogen progesterone. When we study menstrual cycle, we usually study estrogen progesterone graph. Do see, take a look at the testosterone graph too, right? As you can see, all these hormones are at the peak at the ovulation time. So at the ovulation time, while estrogen and progesterone both are giving rise to follicles and ovulation, the testosterone is acting as a primer, where, as we all know, during the peak of the ovulation cycle or the 14th day of the cycle, there is increased desire also. So at that time, all three hormones are actually having the interplay, right? So all these three hormones, next, are having an effect on the sexual desire in women. The gradual and age-related cessation of ovarian function decreases at decreased levels of ovarian steroids too, and there is diminished sexual desire, which causes insignificant portion of the postmenopausal women. There is reduced amount of sexual desire. As we go ahead, we shall see. Next. So let's understand this. The testosterone and estradiol act centrally and peripherally to promote desire and arousal. They also facilitate blood flow and vaginal lubrication. The nitric oxide causes vasodilatory effects, which facilitate blood flow and vaginal lubrication and also promotes the arousal response. Dopamine positively influences the pleasure and reward pathways in the brain. Norepinephrine is important for sexual desire and motivation, elevated during sexual arousal and orgasm. Serotonin, it restricts the excitatory system activated during periods of sexual inhibition. So when serotonin is more, there will be less of inhibition and more of promotion of the desire. Next. Same thing. So per se, dopamine, estrogen, progesterone, and testosterone, they play an excitatory role, whereas serotonin, opioids, and prolactin play an inhibitory role. Next. It is hypothesized that the decreased sexual desire may be due to reduced level of excitatory activity, increased level of inhibitory activity, or an interplay between both, and which may go on changing. Next. So, the women with sexual desire disorder do not per se usually come to a sexologist clinic saying that I don't have desire. Men would do that. More often than not, men would come and saying I don't feel like it or I'm not getting this thing. Afterwards you will come to know that they have the basic desire but they are developing an erectile dysfunction or a premature ejaculation or a marital problem, so on and so forth. But women per se do not come up and say I don't feel like it. Because women don't always initiate. Because they don't have the pressure of performance. Theirs is a more of a responsive desire phenomena, right? But then how do you know that this female will be having a desire disorder? Most of the time in Indian settings I have seen, it is usually partner reported. The partners will come to the sexologist and say that my wife is not involved in this thing, she doesn't feel like it, she doesn't want to do it, or she's trying to avoid it. So then it can, start from anything. Then it comes to asking whether it is purely desire disorder, it is aversion disorder, is it dyspareunia, is it a pelvic infection. So because they don't come up themselves, because it is partner reported many times, we have to rule them out for all the types of FSDs by taking a good history. So, but as such, after ruling out the rest of the factors, we'll come down to the desire disorder, whether the person has a desire disorder or not. So the best thing to do is to be able to confirm that this is purely desire disorder or dyspareunia or vaginismus. We use a screener, right? Next. The three domains that that we actually, while taking history, we'll look at the history and assessment, we'll be looking at the 3 particular domains. This slide is not taken from anywhere else. This has been prepared entirely by me as per as what I understand of the subject. So the first thing I would ask is age and stage of life. How old she is and what is thing. Every postmenopausal woman does not suffer from a desire disorder. I have multiple postmenopausal or climatic women coming to me saying that they have much more desire now that they are free of unwanted pregnancy. Okay, so it's not necessary that every woman who comes to you, every postmenopausal woman has a desire disorder. No, there might be other challenges, right? So the first thing we will see whether age is age related. If it's a young woman in a reproductive period and she has a desire disorder, it can be a lot of, it can give rise to a lot of algorithms like that. So we'll see age and stage of life. Stage of life, why so? A person who has got children or who is about 40-45 years old, where the children are also grown up, where maybe the husband may be touring or the husband may be living at home, right? But depending upon the financial, depending upon the family stress, depending upon work stress, after 40 years of age, people are working and setting their financial future. They are not into the romantic phase of life. So age and stage of life will tell you what is normal for what age desire actually. I mean, you cannot expect a person to be at the age of 40 and expect to be as romantic as she was in 20s, right? So then at that time we also have to see what are the physical ailments or comorbid conditions. In younger age group, PCOS, just the diagnosis of PCOS, obesity, primary infertility are again the major factors in women where they will say I have no desire. Medications that she may be on for whatever reasons, history of any trauma or surgery. By trauma I also mean spine trauma. Women drive a lot nowadays and they are also prone to multiple accidents. The second domain is interpersonal or marital, wherein we ask for whether the partner has any sexual dysfunction. Okay, then is there a mismatched desire? One person feels like it at the same time the other person is not feeling like it, or there is a marital discord. The third domain, most important, is the personal, where you assess the person as a person. Okay, when you want to know what is her sex education level, what does she understand about sex? Does she think that being in bache ho gaye to kaam khatam ho gaya, now there is no need to have sex? Or is she very much into some ritualistic practices where that particular thing is so important to her than having a proper marital conjugal life? Self-esteem, what does she think about herself? A woman does not think I am sexy enough, is unlikely to have much of desire. Her value systems, how much importance she wants to give to the sex? Does she think it's a chore because the husband forces her on her? Okay, what is her value system? Does she think it as a taboo? Does she think it as a dirty thing? Whatever. And the amount of stress she is carrying, with the physical stress or environmental stress. Next. This is how a typical decreased desire, sexual desire screener looks. Next. Next. So this actually has only 5 questions. Next. I just made it more legible. Okay. So question number 1 to 4. If there is the person says no, there is no HSDD. So that diagnosis is ruled out. Then you have to look at other causes. If there is yes to question number 1 to 4 and the answer is no to question number 5, there is HSDD might or may be present, and it might be available to psychotherapy or relationship counseling or maybe pharmacotherapy. If the woman says yes to question number 1, 2 through 5, there is severe HSDD present. The causes that you have to look for is now evaluate utility causes, look for hormonal profiles, look for whether there is partner's sexual dysfunction, whether there is depression, whether there is dyspareunia, or whether there is a history of surgery or psychotic medications, antipsychotic medications. Next. So, in general, I would say, we'll look for chronic medical conditions like arthritis, like cancers, like fears, like depression, schizophrenia, medications the person is on, history of surgeries. Only the surgery for hysterectomy and oophorectomy may not be necessary. There are a lot of thoughts. If the person undergoes surgical menopause, she will immediately have cessation of her all any sexual feelings, or if there is a normal menopause, she will have this thing. There are multiple thoughts and debates about that, right? But then it is a subjective feeling. If the person is undergoing a fear कि अभी मेरा hysterectomy हो गया तो मेरा सब कुछ खत्म हो गया, in that case, okay, she is going to think that only, right? So you have to, whatever surgery she has undergone, now it can be a hip surgery, or it can be a cancer surgery, or it can be just a usual hysterectomy. So any of the surgeries might have an impact on the life. So we have to look into the history of them. Psychosocial factors, how well she is adjusted to her life, and to her marriage, and to her surroundings. But not necessarily increased age. I stress upon this point once again. Both pre and postmenopausal women can have HSTD, although the frequency will vary by age. Postmenopausal, there will be more incidences than premenopausal. Next. If the person has been on any antipsychotic medicines, and whether or not we like to think about it, whether or not the person has a prescription from a psychiatrist, it is possible that the person might be taking something like clonazepam or Restil, alprazolam on its own or something. There are a lot of people do experiment with a lot of things nowadays. So let's see. The hyperprolactinemia, which is usually the side effect of many of the antipsychotic medications, we have named a few of them, right? It is associated with hypogonadism due to inhibition of hypothalamic release of LHRH, resulting in low levels of estrogen and testosterone. So that's how the antipsychotics act on the pituitary and then onto the gonads. Olanzapine is much safer, though it causes a transient and a small rise in prolactin. It is much less frequent. So olanzapine out of antipsychotics is much this thing. So if I have a patient of schizophrenia, she is on olanzapine, I wouldn't be so much worried about her desire disorder than I would rather worry about her schizophrenia itself. You know what I mean, right? Risperidone, which was quite earlier this thing, but nowadays because actually of all our conferences and many psychiatrists are also being educated into sexology, they are being very careful about giving risperidone. Okay, because it's known to cause a lot, though it's a very wonderful drug, known to cause a lot of sexual dysfunctions in both men and women. It causes rapid dose dependent rise in prolactin, and which remains for a very long time. Next. So some more causes. Apart from medications, opiates, cocaine use, protein signaling pituitary adenomas, severe primary hypothyroidism. Hypothyroidism, many women will say, I am hypothyroid, so I go do this thing. It is many times depression related to hypothyroidism. Hypothyroidism per se does not cause desire disorders. And they also have problem with obesity, or they think that they have a problem. Okay. Primary hypothyroidism, liver cirrhosis, end-stage renal disease, and high dose estrogens. Next. Next. Other medicines we block the dopamine release are phenothiazines, butyquinones, metoclopramide, risperidone, and some which deplete the dopamine are methyldopa and reserpine. So as you can see, even our anti-motility drugs and even our blood pressure medicines can have the potential to deplete the dopamine and in other ways cause the sexual desire disorders. Next. The most common cause in both premenopausal and menopausal women, in Indian settings at least, are the relationship dissatisfaction. It is the most important precipitator for female sexual desire disorders. Premature ejaculation, I think it harms women more than the men than it harms the women, because men usually they think of ejaculation as their own subjective pleasure thing. Not many women even expect that, or maybe because of the Google and because of so much of material going on the internet, women think premature ejaculation is very common. We should get through it, and I am supposed to abide by it. So a woman would like to stay in a relationship despite the fact that there is sexual dysfunction. The man may or may not get a proper treatment. Unfortunately, in India, no sexual dysfunction gets addressed by both the partners. Usually it is always the one person. And when it comes to premature ejaculation, the men always show up themselves, but they never bring the partner in. Because of that, what happens? One person cannot be treated fully. It's a couple thing. It's not a mechanical thing कि button दबाया तो ऐसा हो गया. It's not a computer program. Even programs run differently on different systems, right? So because of that, many times the woman's problems are not addressed. Premature ejaculation का females के ऊपर क्या असर होता है? The thing is that there is a lot of reduced sexual satisfaction. Women are frustrated. There is a lot of intimacy. They start hating the partner because they cannot get satisfied. And there could be interpersonal difficulties. And I've seen women who are staying in a long-term relationship with a partner having premature ejaculation who have absolutely hold a contempt for their partner, which is quite a sad thing actually. Erectile dysfunction, once again very well discussed. Difficulty with orgasm and reduced sexual desire. It's like, there is something they cannot help. Even if they want it. The partner is dysfunctional. And the partner is thinking, I am the problem. What about her? What is happening to her? That actually, does not get addressed very well. And women tend to get more frustrated because of that. Next. 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 So when it comes to relationships, I would say the concept of revenge is misleading because it implies that there is something wrong with the woman who has it, when in fact it is often the relationship that has the issues. Now I have multiple male partners who come there, bring their wives and say she is frigid, she is not interested. You take the history separately, you will come to know that actually the male partner has either a ED or a alcoholism or maybe a PE problem, and she is not satisfied, she doesn't want to go for it. Finally, it is a reward mechanism that will feed the next desire cycle, right? When there is no reward, she is keeping quiet about it, but she develops absolutely frustration and she says she uses sex as but she wants to avoid it because she is not getting anything out of it. And the woman is labeled as being frigid or not having a desire disorder. So when you start interviewing one partner, a lot of skeletons will fall out of the closet. Next. So how do we approach these patients? What do we do? Physically treatment. First we'll see the modifiable factors, right? We'll look for sexual education and partner involvement. We'll look for non-pharmacological intervention. If the symptoms are mild and there are contraindications to hormonal therapy, you will try non-hormonal local therapies like moisturizers or psychological interventions. You might want to try pelvic floor physiotherapy or dilator therapy or sex therapy or CPT. Moderate to severe symptoms not responsive to non-hormonal therapies, then non-hormonal therapy, then you will try the local hormonal therapy. Usually we try to limit the local hormonal therapy to a few weeks in a time, once in 3 months, once in 6 months. One should not ever forget the reason, should always rule out the dyspareunia factor, especially in an elderly female, because unless you treat that dyspareunia, no amount of drugs are going to really improve the desire. Next. So these are some of the agents. Intrarosa, that is vaginal progesterone pessaries. They can be used to treat vaginal atrophy in postmenopausal or climactic women. Next. Ospinum is a selective estrogen receptor modulator, also helps treat the vulvar and vaginal atrophy and dyspareunia in the elderly women. Next. Local estrogen therapy with stress, Primarin or vaginal tablets of Lagifem. Next. Tuberone. Tuberone was used much earlier and still is a good agent because it influences the availability of estrogenic compounds for the estradiol receptors in the tissue. It will work maybe in a premenopausal, not in a fully postmenopausal woman, but it has a beneficial effect on the climactic symptoms and sexual function of the postmenopausal woman also. Seems to have an advantage over conventional hormonal therapy in improving desire and arousal both because it works all over, not just at one place. Next. Flumaxine is the FDA-approved drug. It works by centrally acting 5-HT receptor agonist, increases the sexual desire not only by lowering the serotonin in the brain, but also by increasing norepinephrine and dopamine neurotransmitters. A wonderful drug, though not very easily available everywhere. We still have to import it. Next. Bremelanotide is a melanocortin receptor agonist, right? It can be given on demand, substituted by injection about 45 minutes before the activity. Works by increasing the sexual desire and arousal by recruiting the dopaminergic neurons. Okay, but do rule out medical, psychiatric conditions or relationship issues before using bremelanotide. Next, Lipido. basically works on the social motivation and insensitive to sexual cues. It might be better in the earlier period of life, or people who have problems with some retardation or other development problems. You can use subliminal testosterone or plus sildenafil combination. The libido S has subliminal testosterone plus 5-HT1 receptor agonist, that is buspirone. Next. Bupropion sustained release in high doses, 200 mg to 300 mg per day. It works better when the person has been on SSRIs. Okay, the person has been on SSRIs and has disturbed his serotonin and dopamine levels. That is when bupropion works very well. Bupropion is besides the good thing about bupropion is short acting. It's not like you are going to have 24 hours or 48 hours action. Next. Female androgen deficiency syndrome is something that we should pay attention to. Where people think every low sexual desire problem in men and women. लोग लगता है androgen कम हो गया, testosterone देके ठीक हो जाएगा. You know, that's what, and that's what is thought for women also. Yeah, it might be partially true because testosterone is the motivating factor for desire. But there are slight things that we need to pay attention to. Multiple trials include testosterone. Yeah. That the menopause-related decline in women's sexual desire is more closely associated with the loss of stimulating estradiol rather than testosterone. Davis' trial shows the low testosterone levels were not associated with low scores of any of the sexual domains assessed by the PFCs, including sexual desire. Right? So, if you try to female androgen deficiency syndrome, you will have effect on the bone mass and depression and other these things. But sexual desire per se is not really dependent on the female androgen deficiency. Next. So, it was thought as a cure for all, but please remember, we require both estradiol and testosterone for the desire. Giving estradiol will improve the vaginal health and will definitely improve the desire, but giving androgens alone is not going to be effective. It has to be in combination with estrogen. Next. Now, this is just the 1 minute I spent on this and this is it. Okay. So how do we counsel these patients? Next. How do we counsel these patients? Project from down, we go for the age and life stages. Do pay attention to foreplay and arousal issues. If there is no foreplay, there is going to be no desire for a woman. Woman gets aroused by touch, okay, not just by fantasies. Hygiene, hygiene of the partners, which people tend to, not pay attention to. Fear of unwanted pregnancies. So many reproductive age period women say we don't want to have sex because I had so many abortions and my husband does not take care of any contraception. He doesn't like to use he doesn't want to have vasectomy, he doesn't want to have barrier or condoms. Stress or physical ailments, we already talked about it. Marital communication, it is so faulty. It is always going to be marital discord and mismatched desires. And the words that people use about each other, like I said, people, partners bringing the female partner saying that she's pretty when the problem is their own. And people really call each other very dirty names. These words hurt, being infertile, banj hai tu, ya tu frigid hai. These words, they hurt deeply to both men and women. The prognosis goes from down to up actually, and the worst prognosis is if either of the partners have punity attitude or a contempt or hostility for each other. Next. Most important thing that you do in their marital counseling is tell them to have a relationship time about all their timetable. Next. 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 Hypersexuality, do we have time for this? Wind up? Only hyper? Okay, fine. Okay, we'll just go to the last 2 slides. So next. Next. Just see this. Yeah, next. Next. Yeah, just remember one. So hypersexuality can be due to physical lesions like spinal cord lesions or multiple or neurological lesions, but compulsive sexual behavior is common in both in men and women. What we call as sexual addiction, what we call. Next. But DSM-5 does not describe it as a mental health problem. Next. Next. Hypersexuality or compulsive sexual behavior was unreported in women because women don't usually talk about it or do not really display their activities. Next. Next. Finally, what matters? The woman is like a bud of a flower. She needs to bloom, and she will not bloom unless there is a bee to buzz on her. So it's depends on a man to rouse her, to fire that desire, and vice versa, of course. Next. Intimacy is the most important factor that has to be maintained and has to be cultivated and nurtured if you ever want to treat any desire disorders or prevent it. Thank you. Thank you for the.
Hello, the next speaker is Dr. Rajendra Sathe for sexual pain disorder in women. Dr. Rajendra Sathe.
As sexologists, we have been trained to look more into the male sexual issues, and that is what most of the male doctors do. But there is a host of issues in the female sexual problems that we face when a couple comes to us. And next, please. And that is the genitopelvic pain and penetration disorder in human females. So, next. No, back. Yeah, okay. Okay. So, I am Dr. Rajendra Sathe, I am from Pune. And now with all these delays that have happened and all the, we see people coming to us for non-consummation of marriage, where people are married, where a couple is married for maybe 5 years, 6 years, 7 years, and it is usually the genital pain, penetration disorder that the couple is facing, and the exact reason as to why this is happening is sometimes remaining undiagnosed. So I will be just discussing this topic with you in the next 15 to 20 minutes. Next. So vaginas come in all colors, shapes, sizes, and everything. Next. And this particular term nowadays, which is used for genitopelvic pain penetration disorder, it is an umbrella term for vaginismus and dyspareunia, which were the terms used in the past. So now this is the term that is used as per the DSM-5, and it sometimes becomes difficult to know what is it exactly, the reason why there is dyspareunia and vaginismus. So now we are going to explore those reasons and try to come to some conclusions. Next. So to find the causative factors behind the common sexual problems, as I mentioned earlier, and to diagnose, basically what I always feel is important is that we need to know exactly why the problem is happening. So that is what we will be discussing today, so that we can manage the problem of female sexual dysfunction, and specifically as this particular disorder, and to understand the medico-bio-psychosocial approach in this treatment. Yeah, next. So the incidence is varying from 3 to 68% of the population, and this is the worldwide incidence. And have you heard of any condition where it is varying so much? Now, why is it so much? Because you go to the country of origin, and you can see that in Iran, Turkey, and Ghana, it is from 27 to 68%. Unfortunately, there is no study I got of India, Pakistan, and Bangladesh, where I'm sure vaginismus is a pretty big problem. Whereas in Americas and Europe, it is far less. Neither did I find anything more in Thailand, Singapore, and Philippines. But in Ghana, you can see in Africa, it is important to understand why it is seen in those countries. And it is basically the Muslims, Hindus, Jews, and Catholics who have restricted views on sexual morality, which causes vaginismus and maintains vaginismus. Next, please. So how do we go along with over there? It is because of the consistent pain following one or more of the following symptoms. There is a reduced desire and for intimacy in sex. There is a reduced or no desire for lubrication. Pain at the onset or during and after the sexual activity, and reduced or no pleasure in sensation. The difficulty and inability to experience an orgasm in women is a very common problem, and if this is an issue, then the pain factor is one of the contributing factors to that. Next, please. Now we come to the etiology. Now, as I said, that we have to think of the onset, the frequency, and the anatomical site. The woman who has the problem first sends an SOS to the partner, but if the partner continues to, not to heed to the woman, then finally she locks herself up like this and she doesn't allow him to have sex with her. So this is how it usually proceeds. Next. Yeah. So the first sexual act is many of women feel that it is a very painful thing, and then that is mainly because of social imbibed fears and sexual guilt and shame. And this is an issue which is very common in India, and we see a lot of couples with unconsummated marriages where the woman has all these things and they need to be addressed. We should ideally have a couple counselor so that a man and a woman can sit together with the couple and discuss these issues. This is what I found is the most important and very useful thing in my practice. Female genital mutilation. Now this is one reason why I came into this practice. Now I started practice with my father in the early 80s. I had one particular community in my practice, and this particular couple, the woman kept coming and telling me again and again that, look, this is the issue that I'm facing, this is the issue. I sent her to the various doctors, gynecologists, 2 or 3, all of them just examined her and they said nothing. Then while she was discussing this problem with me, she said that, is it because that in our community we remove the clitoris that is causing this issue? She says, I don't get aroused at all. I said, what is the issue? I didn't know at that time that in their community in India it is still practiced. It is the Dawoodi Bohra Muslim community in India where it is still practiced. Even now in 2022 it is still practiced because their religious leader says that it has to be practiced. And they cannot go back on that. But this is done, and that is why this particular problem is specifically seen in their community, and unless you have a very good rapport with them, they will never open up and tell you these issues. Now this forced me to think as to why this could be happening. I gave her a lubricant, and with that her problem was permanently solved. The physical reasons which we will be discussing now, again, which is in the secondary issues which start later on in life, where the woman has had proper sexual act in the past but is now facing these difficulties. Next. So the spasm of the introvital muscles, which is seen typically in vaginismus, we'll be discussing a little bit more about that later. The imperforate hymen and the vaginal septum. So all these things we will be discussing as we proceed in this talk. Next. This is the superficial physical causes which are also seen. Yeast infection, that is candidiasis, then STDs like herpes, then HPV, which is pretty common, trichomonias, scabies, lice, and even pinworms. You might not realize, but pinworms in the intestine can sometimes migrate towards the perineal region and sometimes can cause vaginismus, which can, vaginitis, and then it can cause a lot of pain for the woman. Next. So what are the mental and emotional causes over here? And as Dr. Lampali has has said, that uncaring and unskilled partners, this is something which is unfortunately very much rampant in our land, which is the land of Kama Sutra. But this is there, and we have to talk to the husbands and the partners, first of all, to explain to them what exactly they have to do. Some people are pretty ignorant about it, and some people just don't care about it. Anxiety, fear, and depression, yes, about in their life, whatever they are facing. Partner communication issues, because they cannot communicate it properly in a male-dominated society where the woman is sometimes shouted down upon, and she feels always she's sort of looked down and compressed. She has a compressed feeling about herself. Sexual abuse, it is going on in all communities across all ages, and everyone have faced these issues. It could be verbal, it could be physical, and deep-rooted psychological issues, personality. Sometimes when couples come to me, when I suspect that there is a personality disorder, cluster A, cluster B personality, I get a psychometric analysis done to find out whether either partner is having such a disorder and would require additional intensive consultations from a psychiatrist. Next. So vaginismus, I think all of us are pretty aware about it, that it is an involuntary spasm of the introitral muscles, and which is specifically due to the fear of penetration by a finger or the penis or even tampons. Now in our country tampons are not used, but in the Western countries it is used. But fingers and penis, we have to ask the history whether the male partner is using his fingers to arouse her, whether he is inserting the finger inside, is she allowing him to insert the finger or not. So all these things are the basic things. If this is not being allowed, then obviously she is having vaginismus issues. I had one couple where they were both dentists, and the wife was, when she kept blaming her husband that he cannot satisfy me, he cannot satisfy me. After I talked to him and her, and then finally I was able to talk to her, I called her mother finally. She came, and she was a gynecologist, mind you. This mother came, and when she tried to examine her own daughter, I was present in the room. The moment she touched her vagina, she jumped up and she pushed her mother's hand away and she said, "Don't touch me there." We were able to counsel her, and then finally her mother was able to insert the and do a vaginal examination. But this is what was the condition, and luckily it was her own mother who was a gynecologist, and she had not found out that my daughter is having this particular issue. Next. Now vulvodynia is another common condition where the entire vulval area and even the vaginal area feels like a bed of thorns, and sometimes the woman reports next is that the penis feels like a thorny thorn, feels like a thorn. So actually it could be because of some skin disease. Next, some lichenified lesions, HPV and all those things, they can sometimes give a lot of discomfort and pain, and this has to be diagnosed properly if you have to treat it properly. Next please. So the deep dyspareunias like the chronic pelvic infections, cervicitis, and all these conditions like endometriosis, dysmenorrhea, abnormal bleeding. So all these require, including gluten, require a proper history taking and a proper referral to a gynecologist also, because these are sometimes outside the realm of a person who is practicing medical sexology, and this is where we need to take help of the other people in the field, and all these things can be treated properly, and if they are managed properly, these pains can go away. Next please. Yeah, so the first and the most important thing is the pelvic examination to rule out any physical abnormalities by focusing on the vulvar skin, the labia majora, minora for all these diseases which I mentioned earlier, the clitoral hood, the meatus, and all those areas for abnormal skin lesions like sclerosis as I mentioned earlier, and the perineal area where I said as the episiotomy scar which is sometimes present for after pregnancy and delivery, there is episiotomy, and then that can cause pain and especially discomfort in the sexual act. Next. So how do we do it? First of all, we take a cotton swab and map the areas with fully provoked conditions. Then check the entire vestibule from 1 to 11 o'clock, or sometimes only posterior, based on the area that she points out to you. And palpation and digital examination of the pelvic floor is also important to find out the hypotonicity, the levator and muscles, and a speculum examination to do the deep examination inside the vaginal wall. Next. Yeah. So, what do we do about these people? So, how do we treat them? So, we have to treat them by giving them proper advice on local hygiene. As I said, as Srini said earlier, that many a times women are careless about their local hygiene areas, and then we have to tell them about that. Then the self-exploration and desensitization, especially women who have got vaginismus or fear of penetration, they are advised to do all these things. It's easier said than done. Many a times doctors just tell this, gynecologists tell this, and then the girl just goes home and does nothing about it. The pelvic floor muscle exercises and all those, all those stretches and breathing exercises, though we teach, sometimes are not followed properly, and the problem remains unaddressed. Mindfulness and relaxation techniques with graded exposure, vaginal trainers and wands is something which can again be advised, but sometimes if a female counselor is there, she can actually be with the patient and show her out how to use it, because even if we tell them to buy it and try it at home, they still are afraid, and a female counselor is ideally much well suited to do all these things. Next. So as I said, the vaginal dilators, wands, which are available in the market, which we can buy, and these are pretty useful because they are from graded sizes, and it helps the girl to develop the confidence inside her. So this is something I tell them to buy from the market. Next, please. This is another apparatus which was advised. It is not very popular now. It is called the Gyneflex. So you can see over here, this is being inserted and it expands and relaxes. But I don't think it has become very much in the vogue. It was there maybe in the 80s and 90s, but now we don't use it very often. Next. Yeah. So medication with, first of all, as CBT is very useful. So this is something which we have to sit with the patient and explain to her and the couple again to help them to understand that genital pain is a real thing. Though physically there may be no disorder, she may be checked by 5 different gynecologists, but yet the pain is still there. It is not imaginary, but it has to be addressed. Sometimes medicines are given, but I am not so much for it. Botox injections have been proposed, but again I have not used it on any of my patients. So this is academic for me also. Next, please. Yeah. Next, please. So these are the references that I used for my this thing. In case anybody wants to know more about it, so I will be there. Next. So if there are any questions, I think we are running short of time, so we skip that. And the final thing is that I think I have finished well ahead of time. I am sure that it has not been premature for you guys. but I think the next speakers are there standing in the queue, so I will not take much time. I'm glad that you got these things.
Since we are behind the schedule, coming premature would be appreciated.
Yes, I knew that.
Hello delegates, whoever has not gotten their kit bag, delegate kit bag, please collect it after you are done with the conference.
Those
Today
who
itself.
have registered
Yeah.
have not collected their registration fee should collect it by today.
Yeah, please do collect it by today evening.
Thank you, Satya sir, for the nice presentation.
हे ब्लँक कशासाठी स्पॉट वाल्यांसाठी
Invite my teacher and starting from my sexual medicine practice is the person behind my course. I did my masters in reproductive and sexual medicine. And sir, I invite Dr. S. Murugan sir to talk about the genital hygiene over to you, sir.
आंबे बुढ़े हो गए
अभी क्या करें बेटा?
Good afternoon, everybody. Already hunger contractions started. Very difficult to have a listen. Thank you, Rajit, for good words. And thanks for the organizers for giving me this opportunity.
First conference.
Today's my topic is genital hygiene in women and girls. So why genital hygiene is important for both sex? No doubt. But in women, it has a special focus that is very important, about which we are going to talk now. No, it's not working.
You just say next.
Yeah, you only come. Yes. So the challenges in women is more because of that shorter urethra and close approximation to the anal orifice. That's number one. And menstruation and so many things we are using for menstruation, sanitary pads, tampons, menstrual cups, etc. Sexual activities, condom, foreign bodies, bits of cotton. Sorry. No, previous slide. Previous slide, please. Yes, foreign bodies, bits of cotton, clothes, and other which is used for stop the bleeding and needs cleaning every time after toileting. Inadequate and intolerable restroom facilities, lack of privacy to change the pads, faulty washing habits. Next slide please. Not restricted, it's more. More area is exposed during sexual act than in men. And being a receiving end, the infectious material remains more time in spite of vagina have a self capacity to clean itself. Not able to visualize the intravaginal part, women will see can see the external genitalia, not the internal genitalia. Not only that, even the external genitalia also sometimes may not be visible with the individuals who are having obesity or in pregnancy. Difference between children and adults are there. pH is different, the lining epithelium is different, so children are more vulnerable rather than the adults. Can I have the next slide please? So the feminine genital hygiene includes normal daily cleansing, menstrual hygiene, sexual hygiene, care during special circumstances like vaginal discharge, infection and extremes of pain, about which we are going to discuss now. Can I have the next slide please? A healthy vagina is a population with a good number of bacteria acting as a gatekeepers for the vagina as they prevent the growth of the harmful bacteria. The pH of the vagina is acidic. It's also having a protective action which will be disturbed by periods, soaps, deodorants and intercourse. Of course, intercourse, that is semen also is alkaline and it will change the pH to an extent. Vaginal odor is not only because of poor hygiene, it is also because of the pH change due to, and the pH change will predispose the infection. Because of the infection, the patient will have odorous discharge, especially bacterial vaginosis, sometimes even trichomonas or secondary infection or anaerobic infections like that. Next slide please. So the various types of bacteria are balanced by lactobacilli. Lactobacilli is common in women, in adults, not in children. Because of the action of estrogen, the glycogen, that is vaginal epithelium, becomes rich with glycogen, which is replaced by its lactobacilli or lactobacilli, which is responsible for the lactic acid production and acidic pH, which is lacking in the infants or children below 12 years who are not having the estrogen action. So they are more vulnerable for infection. Children are more vulnerable than the adults, in spite of they are not having the sexual practice or menstrual habits. And these are the anaerobic organism, that is Peptostreptococci, bacteria, Phytosporidium, and other organisms are being checked with the Dodling specially. That is very important, which is not when the pH is disturbed, it will be disturbed. Next slide, please. So normal pH ranging from 4 to 4.5. And the vaginal pH increases when the lactobacilli decreases. When the lactobacilli decreases, the pH will be increasing, and they are more vulnerable for bacterial and candidal overgrowth. That is an important thing. Next slide, please. Can I have that slide, please? Yes. Imbalance in the vaginal pH is due to unprotected sex. Semen is alkaline. Antibiotics, which kills the useful bacteria, harmful, non-harmful bacteria, and the proliferation or growth of harmful bacteria will be taken upper hand. Menstruation increases the pH in the vagina. Pregnancies, the pH may be altered because of hormonal action. Frequent use of harsh soaps and chemicals. Infections like bacterial vaginosis and trichomonas vaginalis also can cause the pH variation. So these are the causes for pH variations. Next slide, please. So this is the situation in the whole world. 50% of the Indian girls are not knowing about the menstruation or the pad using before they have their own. And 16% of the women and girls in India had not access to the sanitary napkins due to cost. 28% of the women and girls in Indonesia miss their work because of the period, and another 60% from the Nepal, they are avoiding social get-together gathering functions because of the menstruation. And 13% of the low income and middle income group, they are not able to afford to buy. So because of that, they are dropouts from the schools. So how can we help? By making proper approach, access to the sanitary facilities and napkins, no cost, and toilets, so many things. By only we can improve that status in the children. Day-to-day hygiene. So this is number one. Clean the vulva and vagina with plain water after every act of maturation to avoid swelling, irritation and infection. Unlike in men, the last part of the urine dribbles over the external genitalia, which will produce irritation and smelling, all these things. So the women has to, previous slide please. So women has to wash every time after that using toilet. Wash from the front to back, never to the back to front. So you can see the mark like that. Front to back, never to back to front. It will lodge the fecal materials and it will produce discharge, especially discharges in young women who are not having sexually active is mostly because of this faulty washing technique only. Because of that, they discharge the motion particles from the back to front. And use soap sparingly. Take care to clean the labial folds and the clitoral hoods. Pad dry with soft cotton towel tissue. Use loose fitting cotton underwears. Change the underwear at least once daily. In humid climates, preferably twice. Next slide please. Avoid forceful washing. The jets, toilet jets should not be used. High pressure jets or water, vaginal wash also should not be encouraged. Harsh chemicals and soaps should not be encouraged. And frequent douching is not necessary. Previous slide. All of the above will interfere with the normal vaginal environment, pH and flora. It will disturb. Yes, next slide please. So, keep the genital hygiene clean, keep the groin dry, avoid the cleaning from the cleaning agents, avoid unnecessary agents, douching, chemicals, vaginal wash, V-wash, and all not at all necessary. Next slide, please. Pubic hair removal is not an important one to maintain the genital hygiene. This is we have to accept. If at all, if you want to, that is, the pubic hair acts as a cushion and protective barrier for the vulva. If at all you opt to remove that you want to trim, it can be trimmed, not to be shaved. If you prefer shave, you have to use one-time using razor, disposable razor, and adequate foaming, moisturizing, and dry shave should not be encouraged, and visibility, good visibility has to be ensured. Otherwise, it may likely to go for injury. Waxing generally to be avoided in the genitals because it may lead to folliculitis. Depilatory creams may be avoided, may be produce irritant contact dermatitis. Laser hair removal may be opted for semi-permanent method. Can I have next slide? Hygiene tips during menstruation. The pads has to be changed every 6 to 8 hours. It should not be more than 8 hours. The safe disposal of urine that is used sanitary material is also very important. The used sanitary material, sanitary pads should not be thrown in the corporation waste or normal waste along with the household waste. It has to be either disposed, there is biomedical waste in the hospital, it is possible. But in the house, it has to be buried deeply or it has to be incinerated. So, because there is every possibility the blood, the infection born through blood, especially HIV, HCV, HPV, can be contaminated to other persons. Next, previous slide. Previous slide, please. Previous slide. Previous slide. So, hand washing after changing the towel is very important. Using tampons, you should not forget to remove it, especially when the periods is the terminal stage. Twice daily bathing is preferable during menstrual time. Next slide, please. So, this is very important to restrict the time of sanitary pads 4 to 6 hours. That is very important. Next slide, please. So, these are the things we can use for menstruation. That's apart from the sanitary napkins. Previous slide, please. And apart from the sanitary napkins, we can use menstrual cups and tampons. Next slide, please. And the menstrual cup is we can extend the time. We need not give importance to change frequently. Even it can be kept for more than 12 hours. So only thing, it has to be, it is made of a silicon rubber, and before introduction of the menstrual cup, previous slide please. And before introduction, we have to wash the hand. After gluing, we have to wash the hand, and we have to clean the every time this menstrual cups, and it has to be folded. It can be inserted, introduced into the vagina. It will be very useful and can extend the timings. That is very important. Unlike the sanitary pads. Next slide, please. Sexual hygiene. Wash the genitals, genital area before and after sexual intercourse. Not only after, before also. That will be always useful, especially oral sex and all things like that. You use barrier protection, unless you are active to trying to conceive. Though sexual intercourse during menstruation is not contraindicated, there is a slight degree of infection may be possible. But menstruation, I hope no couple be exempted. I didn't have intercourse during menstruation, nobody can tell. Because at the end of the anything or beginning, sometimes uncalculated, unexpected, even the women may not be knowing at that time this type of contacts are there, but nobody is getting anything. So it's not a thing to be worried. And if there is several genital itching, severe genital itching after intercourse, we have to rule out the allergy to spermicidal drugs. Previous slide. Condom and lubricants, spermicidal jellies, etc. Definitely avoid sexual multiple partners to prevent from the sexual transmitted disease. Next slide, please. Self-medication as far as possible should be avoided, especially prolonged antibiotics and steroids may predispose secondary infections. Prolonged antibiotics, candidal overgrowth is be expected because of the harmful, that will destroy the normal vaginal flora. Steroids will lower the immunity, so that naturally it will produce. So self-medication has to be avoided. It will affect the pH. Next slide please. Vulvovaginitis in children, that is very important. Children is different. Their pH is it's not acidic, it's alkaline, and because of the absence of lactobacilli, I told already. And the lining epithelium in adult women is staphylococcus squamous epithelium, whereas in children is single layer of cuboid epithelium. Because of these two reasons, children are more liable for infection. Infants cannot take care of themselves. Customs and fancies and faulty habits of the parents have influence, and usage of diapers, pampers, cleaning habits, mother's hand hygiene, etc. have a role in child's morbidity. Especially we are coming across so many people who are using huggies and pampers using for more than 8 hours. So this all contact with the urine, contact with feces will definitely predispose infection. And clothing, children playing with the innerwears. So previous slide please.
It's changing automatically.
Previous slide please. So children with vulvovaginitis will complain of pain, itching, burning around, and vulvovaginitis in children can be caused with bacteria, fungus, parasites, irritable applications, skin disease, sex abuse, and foreign bodies. Next slide please. So they cannot take care themselves. Customs, I already told. Yes, next slide please. Economic conditions, not wearing innerwears and playing in the mud, playing in the floor, maceration, friction, prolonged contact with the urine, feces, habits putting fingers into the genitals, and clothing without innerwears and without playing without innerwears. Worm infestation, already previous speaker told that worm infestation, especially fever from the anus to, it will migrate from the anus to vulva, causing itching, scratching, and painful thing. Vulvovaginitis also being there. Previous slide please. And foreign bodies is not rare. Pebbles, stones, writing objects, beads, grains, nuts may be inserted themselves or the playing mates. Sex abuse is a least but not a last one. Next please. Next slide please. So last not least. Okay. Female infants and children hygiene. So that mother has to take the teaching is very important, and cleaning should be done front to back and not to the other way. Remember, dry the folds. Ensure fecal matter is not left around. The anus should be washing. So supervision by the mother is necessary then and there till the menarche. Disposable diapers should be changed every few hours. Preferably a zinc oxide cream can be applied before wearing the pampers or something. Next slide please. Old age, so they are more vulnerable because of the atrophy of vagina, the diabetes, all these things. They may have stress incontinence, and they have to look for severe hyperglycemic control, and they can use moisturizer, and they should not be, nobody should use the fragrance and spray and other things for better hygiene. It also will produce allergy, contact dermatitis, leads to pigmentation. Next slide please. And jets, I told already, you should not use harsh, especially intravaginally. It will lead to the external flora enters into the genitals, and also it will lead to change of pH. So they will be more vulnerable for infection. Vaginal wash, it's not necessary. It is not necessary to be encouraged. Next slide please. It will also disturb the pH. Next slide please. So be safe. So this can be very useful when we are sharing the toilets, especially during travel and other things. It will clean the seat, so that will prevent most of the skin diseases and other things. And vaginal steaming, vaginal spa is not necessary. Usually it's not helpful. Next slide please. That vaginal tattooing, piercing should be avoided. Next slide please. And sex education is very important from the school day onwards. Genital hygiene should be stressed in this sex education. Regular cleaning of genitals is necessary for happy and healthy sexual and reproductive life in future forever. Over enthusiastic deeds will worsen the situation. due to hypersensitivity, alteration of pH, normal flora and ecosystem make it vulnerable for infection and other pathological conditions. Unnecessary obsession about over-hygiene also should be avoided. Avoid browsing. Google will complicate your problems. Next slide, please. The vulval area is delicate and alters with age. Avoid harsh cleaners. Keep area dry. Vaginal discharges should be tackled urgently. Pubic hair removal is not necessary for maintaining vulvar hygiene. So, take care of your genitals. As already some other speaker told, even the hygiene of the partner will make the unconsummated marriage, will be leading to aversion, all these things. So genital hygiene is very, very important. Have a nice sexual health for a nice sexual life. Thank you very much.
Thank you very much, sir. So, before leaving for the lunch break, so let's have the felicitation part. So I request Dr. Tariq to give the Dr. Tariq had to give memento to Dr. Ashwini Vivek. Madam, please. Dr. Sathe. Say, Dr. Tariq Khan to give to Murugan sir.
From the computer to be the how to know it?
Dr. Sathi is giving trophy to Dr. Ajit Chakraborty.
How's the lineup now?
That's what we are waiting. Now they're announcing for the lunch.
No, lunch. Yeah, no. You Dr. Rajendra, sir. And then after that,
Dr. Sathe is honoring Dr. Atif. Tariq.
So that concludes the morning session. So we will be continuing the session after the lunch.
Vivek, I will just see what happens now. We are at the my belongings are dumped in here.
So those words, these are very precious to me today.
Incidentally, I am not worried. You have to worry about them. That's
क्या बोलो उसका नाम और उसके बाद में पसंद तुम्ही काय प्रॅक्टिस करता? अच्छा, मग खूप मोठी प्रॅक्टिस करता. बिहाइंड एव्हरी सक्सेसफुल मॅन देर इज अ वुमन. गुड. या अशा कसं आहे आणि अशा यू अंडरस्टँड मराठी ना? या सो दिस ऑफबीट specialities or offbeat fields like sexology or any other field for that matter, before marriage you require support of your parents. अरे जा बिंदास कर, मी आहे तुझ्या पाठीशी. And after marriage you require the support of spouse fully. की अरे तू कर ना असं. So congratulations to you.
That is your lecture for that Conclave. I come from here. मेरा काम था ना, from that Conclave. बरोबर 12
अभी शुगर बढ़ाएंगे पोस्ट पैंडेमिक ग्लूकोज के साथ. So let's go and celebrate our lunch. Thanks for coming.
सर तुम्ही पुण्यात कुठे राहता?
मी पुण्यात कोथरूडमध्ये राहतो.
खूप फ्रेंड्स आहेत.
अरे मग या ना मॅडम, जरूर या. तुम्ही या, शिरीषला घेऊन या. म्हणजे तुम्हाला सांगायला पाहिजे की त्याला घेऊन या.